All right, welcome back. Let's start our panel. Our first talk in this panel, so we're going to have 4 12 to 15-minute talks.
Excuse me, people really don't know outside. There's a whole gang of people outside.
Amanda, go get them. Rodney, can you get people to come in? Are they people coming, waiting? All right. We're going to have 4 talks and about what's happening in the local community in Atlanta working with health disparities. We have talks from university researchers, from Fulton County, as well as from Booz Allen, and what kind of activities they're doing here in Atlanta. So just ways for us to think about connecting and what's going on and what more we can be doing together. So our first talk is by Loida Bonney. She's assistant professor at Emory University. And her talk is entitled, Impact of Public Housing Relocations, Are Changes in Neighborhood Conditions Related to STIs Among Relocating Residents. Welcome, Dr. Bonney. Let me steal the water I took a drink out of so you don't accidentally drink that water.
Good afternoon, everyone. Good afternoon. Thanks for having me. I'm really excited to be a part of this summit. So as Aaron said, thank you, Aaron, my talk today is I'm going to be talking about our study on the Atlanta Housing Authority relocations. We basically are looking at our changes in neighborhood conditions related to sexually transmitted infections among relocating residents. I have no disclosures. So as a backdrop, many people do know that sexually transmitted infections are a significant problem among poor African Americans. CDC data shows this really clearly. On this slide, you can see by the red line that represents non-Hispanic blacks that the rates of chlamydia in the U.S. are far higher for non-Hispanic blacks than for other racial and ethnic groups. This slide shows the same for gonorrhea. Now, while the rates are decreasing over time, we see from the x-axis that by 2008, they still are quite high and quite a bit higher than other racial and ethnic groups. So why do sexually transmitted infection disparities exist? So multiple factors have been implicated, and there's a large body of literature that actually talks about personal sexual health behaviors. I won't go into that literature. There's not time in this 12-minute talk, but I will tell you that we do know from our research that sexual health behaviors do not explain it all, that there are many issues, including poverty and social conditions, that play a large role. I'll draw your attention to a landmark study that was done back in the 1990s in New Orleans. And in this study, impoverished communities were looked at by various qualities, including housing quality, abandoned cars, graffiti, trash, and public school deterioration. This was all put together in what was called the Broken Window Index. And what was found and reported was that communities that had higher social disorder, that had a higher Broken Window Index, were also the same communities that had higher levels of gonorrhea. The study, of course, was limited because it was cross-sectional, and that's where we hope to add to the literature with our study that I'll speak a little bit more on. Before I go into that, I'll tell you that Cohen et al., the same author of the Broken Windows study, later published this figure in an article which kind of outlines how socioeconomic status and social conditions translate to poorer health outcomes or health outcomes in general. So you see on the left, socioeconomic status leads to physical structures and social structures and the conditions of these. These translate then to situational opportunities and exposures, health behaviors, and all of that influence how people's health turns out. So let's turn a little bit to Hope 6. So Hope 6 is an initiative called Housing Opportunities for People Everywhere. It was developed by the U.S. Department of Housing and Urban Development, and it was created in 1992 with the goal of deconcentrating poverty, essentially. So deconcentrating people from severely distressed public housing complexes with the goal of improving their lives overall. Atlanta was at the forefront of this whole initiative. Before the Olympics began here in Atlanta, housing complexes, public housing complexes were demolished in order to put up complexes for sports. Over the past few years, that final wave of relocating these residents took place, and it offered our research group and others, including one here at Georgia State, the opportunity to study this natural experiment. Will changes in people's social conditions or degrees of poverty translate to improved health? So we hypothesize that adults who experienced greater post-relocation economic improvements would also experience lower prevalences of sexually transmitted infections. Here are our inclusion criteria. We created a cohort of 172 people. We recruited them by sending our staff out to the complexes. We posted flyers. We spoke to people at community-based organizations. We ended up collecting data at these same places. We did not collect data at the actual housing complexes because we weren't allowed to, but we did collect data at community-based organizations, faith-based organizations, and a building over at Emory University, which turned out to be one of our best data collection sites. So our baseline data I'll refer to throughout the talk as wave 1, and thereafter we collected data every 6 months, and I'll refer to those waves as waves 2 through 4. Our measures. So our dependent variable sexually transmitted infection. We had people give urine samples that we tested by polymerase chain reaction methods for chlamydia, gonorrhea, and trichomonas. Our independent variables were personal and neighborhood characteristics that we collected by computer-assisted personal interview and audio computer-assisted survey instruments. And for our administrative data, we used the U.S. Census Bureau data to actually describe where they lived, the neighborhoods they lived in before and the neighborhoods they lived in afterward. We used descriptive statistics and multi-level models, and we ended up actually creating a track-level economic conditions component, which included poverty rates, median income, and educational attainment because they were highly correlated. And here are our results. And just going quickly, for the sake of time, you see the purple hexagons represent where the housing communities were prior to relocation. This map slide shows the first wave of relocations, where the people actually moved to, with the darkest shaded blue being where most of the people moved to, and the black outlines being where people lived before. People moved an average of 5 miles away from their original locations. And so here you see demographically, more than 50% of our sample were women, and they were highly impoverished, with the annual household income being approximately $7,500. At wave 1, 35% of our women tested positive for at least one of these 3 sexually transmitted infections, 12% of our men. This is not unusual. Women are more susceptible to sexually transmitted infections in general, and you'll see that overall prevalence data nationally shows that women have more, so that we weren't surprised by. But what was interesting to us was that the greatest declines in prevalence were seen between waves 1 and wave 2. Waves 2 and 3 for both male and female remained fairly steady, and then between waves 3 and 4 we see that women had another decline and men stayed about the same. There were also significant changes in census tract characteristics. Here we see that poverty rate went down, percent of adults with high school degree or less went down, mean household income actually went up, and our economic conditions factor shows the same. We won't discuss very much here, but male-female sex ratios actually went up, and that's known to be a pretty good thing for sexually transmitted diseases. So bivariate regressions showed a trend toward improvements in sexually transmitted disease rates for people who experienced improvements in their economic conditions. Okay? And multivariate regression shows the same. So just for our discussion, we see clearly here that racial and ethnic health disparities are driven by economic conditions, and our preliminary data does suggest that we can intervene by improving people's socioeconomic conditions. Not necessarily their personal ones, because that we actually didn't do and we didn't study here, but improving the socioeconomic condition of the census tract in which they live. So other variables that we will explore, and we're excited to do this. Again, I said this is a preliminary analysis. We're going to be looking at behavioral characteristics, violent crime rates, alcohol outlet density, network characteristics, and we also are very interested in knowing and understanding the mechanisms through which these changes in census tract translate to changes in prevalence of sexually transmitted infections. Our study is limited, as are most. It was a convenient sample, but I will say that when we compare the demographic characteristics of our sample to the demographic characteristics of the overall Atlanta Housing Authority characteristics, they're very similar, so we got a good sample. And we should also say that when participants tested positive at one wave, we did refer them to treatment, and this could have accounted for why many of them later on were negative for sexually transmitted infections. But it doesn't explain why that difference was correlated with changes in their socioeconomic conditions. So my conclusion, as I pretty much said before, that residential tract level improvements can lead to declines in STI prevalence in poor African Americans. Thanks for listening.
Thank you very much. Okay, next we have Dr. Christina Fuller. She is an assistant professor of environmental health, and her talk is entitled, let me see if I can find it. Here we go. Urban air pollution, implications for health disparities. Welcome, Dr. Fuller.
Okay. So I'd like to say thank you very much. I'm very happy to be presenting this research today. It's very interesting and good that actually I'm presenting after Dr. Bonney, because the populations are very similar, because this project that I'm talking about also has to do with residents and associated with Hope 6. So through the preliminary analysis of data that we've collected, I will discuss how differences in air pollution concentration can result in disparities in exposure and subsequent health effects. So before, we've been talking about health disparities and outcomes, but what I'm going to talk about are exposure disparities and how those can be related to health outcomes. So this slide, I guess I can go through pretty quickly, and I would just note that in late 2007, faculty at Georgia State University began working with the Residents Advisory Board to conduct a study to follow residents through relocation, very similar to what was just presented. And in this study, which is based in the Department of Sociology, it used a mixed methodology to collect both quantitative and qualitative data about the cohort. And data has been collected with residents of 4 family and 2 senior housing communities and 1 non-relocating senior communities, and started out with about 382 residents participating. Data was collected pre-relocation and 6 months post-relocation, and also 24 months post-relocation, and that was completed in November of 2012. So about 87% retention rate, which is actually quite successful. So in addition to information gathered from each resident, the study also utilized built environment audits to gather data on the physical characteristics and resources of the blocks where each resident moved. Community perceptions of participants and neighbors were gathered, and these are some of the pictures that were taken by the students and also the participants of the neighborhoods where participants moved. So some of the findings indicate that residents move to neighborhoods with better housing, that are somewhat safer and have about 10% less poverty, but are just as racially segregated as before their relocation. And each of these elements, housing, safety, poverty, and segregation, are related with differences in health outcomes. However, there are other dimensions of the environment that also affect health outcomes, and they were not captured by the original study, and air quality is one of these factors. So a pilot study was funded through the Center of Excellence at the Institute of Public Health. And in the study, we aimed to examine variation in air quality in different areas. And the specific question we sought to answer and we seek to answer are, do disparities in air pollution exposure exist between these neighborhoods? And what factors drive this disparity? So now there is substantial information on ambient air pollution and its associated health effects. And the majority of these studies have used a central site monitor as the estimate for pollution exposure. So air pollution in urban areas is generally driven by traffic-related air pollution. So that is the exhaust from cars and trucks when they burn diesel or burn gasoline. And this releases a mixture of particulate matter and a mixture of gases into the atmosphere that really drives air pollution exposures. So what we have learned in more recent years is that there is more intra-urban versus inter-urban variation in air pollution. So within a city, there's more variation than when you compare, say, Atlanta to New York or Atlanta to LA. And this variation is driven by proximity to roadways and proximity to other combustion sources. Several studies have identified higher prevalence of cardiovascular disease, lung cancer, and asthma near traffic sources. And we also know that socio-demographic factors such as class, race, ethnicity, and income often drive proximity, so that's how close people live to traffic corridors. And this results in disparities in exposure and disparities in outcomes. So through our study, we aim to make some inroads and address the interactions between the physical and the social environment instead of addressing each separately that has been done in previous studies. So we did monitoring as part of this study. And we measured nitrogen dioxide, which is a gas that is released when cars and trucks burn gasoline or diesel. And it's a marker of traffic-related air pollution. So nitrogen dioxide can be measured relatively easily with monitors called Ogawa badges, which are given right here. It's a passive monitoring badge, so you put it up for a certain amount of time. And then when you take it down, you send it to the lab for analysis, and it gives you the concentration over that period of time for what the level is in the air. Pictured here are some volunteers for our monitoring campaign, which happened in fall of 2012. And our interest is in neighborhoods, therefore we approximated using census tracts. And we selected 4 census tracts of different poverty levels. Greater than 40% poverty, 30 to 40% poverty, 20 to 29%, and less than 20%. And all of these were within Fulton County and were tracts in which participants from the Atlanta housing study had moved. 30 monitors were placed in each census tract, and that provided a total of 120 sites where we collected data. We used a random sampling scheme to select monitoring sites in each tract, and we divided these between high traffic and low traffic areas. In addition to these census tracts, we placed a monitor at a Georgia Environmental Protection Division site, which was southeast of the monitoring area, several kilometers away. And we did this because we're interested in seeing if there would be differences in variation of nitrogen dioxide within our census tracts, and to see how that would relate to this further away site, which is what you usually use in epidemiological studies to look at health effects. We completed the monitoring between October 13th and 27th of 2012, and we had 19 volunteers that helped us do this monitoring. Here are selected characteristics of the selected tracts, and the percentage of the population that live below the federally established poverty line are given there, so exactly in each category, 49%, 38%, 21%, and 10%. And all the tracts were predominantly black, which allows us to examine perhaps other demographic factors more clearly, since we have this factor unchanging between the census tracts. And all those census tracts are designed to have a relatively homogeneous population. The population did range between 1,500 for one census tract up to 6,000 for another census tract. And that perhaps are differences based on vacancy, which you can see is very high in one census tract and a lot lower in this other census tract. So here we present the nitrogen dioxide concentrations in the census tracts. And this table shows the census tracts here, the mean nitrogen dioxide concentrations here. And then here I have a box plot with the mean 25th and 75th percentiles and 10th and 90th percentiles. So what you can see here is that for the highest poverty census tract, you have the highest concentration. And for the lowest poverty census tract, you have a lowest concentration. And the background site is even lower than that, even though we just have one measurement. And this map shows concentrations for each census tract as well. And it's divided into our different poverty levels. These are the 2 lowest poverty levels and the 2 highest poverty levels. You can also see we have some landmarks here. We have Georgia State, which is here, the Braves Stadium, the Atlanta Airport. So you can kind of see how these are spatially associated. And the monitoring sites and their concentrations are represented by the points given here. And the colors gradations are predicted concentrations based on an empirical kriging method where you use nearby points to predict the concentrations between points. And you can see that overwhelmingly higher concentrations are shown near the highway here, 75 and 85, and there are lower concentrations in areas that are away from major roadways. So as Dr. Diaz-Rue discussed a little bit earlier, no model is perfect. And therefore, this map shows the error associated with these predictions. And the areas in green highlight the most confident in the predictions in a particular area. And the red areas indicate those that have a little bit less confidence. And generally, this occurs along the boundaries of our census tracts, like around this area here, which is red because we only have one point there, so it's more difficult to predict concentrations in this area. But where we have lots of points, say here, we're more confident in our predictions of concentrations between those points because we have more data there. In addition, we did some preliminary models, and we examined a few predictors of nitrogen dioxide concentrations that we know from the literature in separate models. And we identified 4 that were significant: poverty rank, distance to an interstate highway, annual average daily traffic, so that's measuring how many vehicles are on that interstate highway, and being in our high traffic area, which we decided between high and low traffic areas. However, in a single model, so a multivariate model, putting all these predictors in one model, only poverty level, distance to interstate highway, and annual average daily traffic were identified as significant predictors. The high traffic areas dropped out. And it's interesting to see that even though we have our typical predictors that in the environmental literature, you say closer to a traffic corridor, you would have higher concentrations. That is significant. But poverty rank is also still significant, even controlling for being close to a highway. So the implications are that, in conclusion, we've seen that there is variation in nitrogen dioxide concentrations within and between our selected census tracts. And this implies that a distant site monitoring may not truly represent our intra-urban variation in concentrations, and that exposure disparities may go unnoticed without having local data. We identify proximity to interstate highway along with traffic volume and census level poverty as predictors of concentrations in our preliminary models. And our next steps are to continue our analyses with the data we've collected and to understand more about interaction with the social environment and the economic environment. And we're also interested in identifying other local sources or sinks, such as auto body shops or vegetation, that may be impacting the concentrations that we find within and between census tracts. So I would like to thank the very large number of people that have been involved in this research. And at the end, I'd be happy to answer questions. Thank you.
So I want to say that there are two reasons I asked for these two presentations. The first reason being that we're demonstrating that Georgia State is collaborating with Emory on sort of sister public housing projects. So here's one way in which there is already university-level type research collaborations taking place. The second reason is I wanted to kind of think about how can we be advancing research and health disparities in terms of the way we're measuring things. So here we've got environmental measures and we have biomeasures from the human body. So this is places that I think we need to be going to really talk about and model health disparity research. But that's only one type of collaboration and research that we could be doing. So next we're going to have two speakers who are involved in the local Atlanta area who bring a very different sort of work to health disparities research. And the first is from Fulton County Health Department. It is Dr. Nazeera Dawood, and she leads the Division of Health Promotion at the Fulton County Health Department of Health and Wellness. So let me pull her talk up. So please welcome Dr. Dawood.
Thank you so much, Erin. Hello, everybody. How are you all doing? Great. Can you hear me okay? Excellent. So what are the 9 most dangerous words in the English language? 9 most dangerous words. I'm from the government and I'm here to help. That's what Ronald Reagan said. So again, I'm known to go over time, so thank you, Tony, for offering your 5 minutes. Usually my second slide is about acknowledgement and thank yous because I think I cannot do this or we couldn't have done this without a team support. My management, Dr. Harris and Dr. McKenna, my wonderful team who supported me and have been putting up with me for these past 2 years. Our coalition diverse co-chairs, Mr. Rodney Mullins, who's the HPAC co-chair, John Stewart for inviting me to be here, and of course Marshall Kruder, who has helped us connect the dots, and you for being here today. If you can see closely at this picture, you'll see diversity already at work. This happened in January. That is a month and a half back on Martin Luther King Day, where we were able to secure this lot for a community garden, and these 2 kids holding hands, coming together, planting seeds for the future, for the community. And that's what, if you want to ask me to show one picture, that's what I want to show, what we've been doing for the past 2 years. Fulton County stretches 72 miles long. It's very challenging. It has 14 municipalities. City of Atlanta resides in Fulton County. 93% of Atlanta's population is in Fulton County. And as you can see, the leading causes of death is almost the same in Fulton, Georgia, and United States, except it's just flipped over here and there. Initially, when I came to Fulton 2 years back, there was no mission and vision in the health promotion division, so I had a fresh start, which is always good. So we looked at what should be where do we want to go? And we looked at the county health ranking system that's put out by the University of Wisconsin, and we learned we had ranked 26th according to the health outcomes and health factors. So we said, you know what? I know where we want to go. We want to be the healthiest county. So my boss comes and says, are you sure? He said, why not 12th or 13th? No, I said, if we aim high, we'll get there, because I knew I had the support of a great team. I don't have to show or talk about this, but as the bite size and the cup size increases, so is the weight of our nation. Technology has helped us, but also has been not a very good thing, as you can see, because it has limited our activity and our health diet has not been healthy as well. So what do we do with limited funds, right? We have limited funds, but obesity is on the rise. Georgia is ranked 2nd highest childhood obesity in the nation. We said we need a paradigm shift. So local health departments are known for health fairs. How many of you know that? right? Anytime you say the health department, oh, they do the health fairs. No, so we changed the paradigm shift. We said, no, we're not going to, at least in the health promotion division. We said we're going to move from health fairs to policy systems, environmental changes. Anybody who interacted with me since then knows my middle name is PSE, which is Policy Systems, Environmental Changes, because I tell them if you come to me to talk about a health fair, no, I'm not the person. But if you're showing me that the activity that you're leading to is going to lead to a change, then yes, please do talk to me. So we moved from a know-all agency to everyone knows something, to I know all, to you have something. People are tired of needs assessments. Believe me, I know. I've heard for the past 2 years. They said everybody's doing needs assessments. So we need to move beyond needs assessment and find out what are their assets, and then let them give up. Sort of, you're giving them, empowering them to show they are an asset to our community and to our approaches. So from silos to coalitions, that's where we went. So we're all working in silos. Everybody in every sector. That's what we realized, especially the smoke-free efforts, the asthma coalition efforts, the diabetes efforts. We have all the resources in the community. And to bring them all together was the only way to make form coalitions. And this is community-driven, community-empowered. It's by the community. We are only giving them a forum and the guidance, the TA, to make them empowered to start these activities. So every time it has been always government imposed, no, we changed the approach, like I said, paradigm shift, and showed them, no, you can do it. So all these representations, as you can see in the boxes, the Smoke-Free Coalition, these are the community people. The co-chairs, always a Caucasian and an African-American. Always a co-chairs in all our coalitions are Asian or African-American, or Asian and Caucasian. So you can see the diversity where I'm coming from. Again, PSE changes. So these coalitions know they have to do PSE. That means sustainable changes. PSE parks, smoke-free parks, smoke-free campus. Actually, we're working with GSU right now to enforce the policy that was recently passed by the GSU administration. And for the Diabetes Coalition, we are trying to address food deserts. We are trying to also, how many of you have heard about Healthy Corner Store Network? Excellent. So we are also working on Healthy Corner Store network on the Boulevard area, where we are transforming the unhealthy corner stores, getting the buy-in from the store owners and the store managers to transform it to a healthy corner store. We are moving from a PowerPoint presentations to power sharing with the community. So the community has really not always heard, it's just like these presentations being offered, but they're never given a chance to come in front and be in the forefront and present to their community members and being empowered. So we're teaching them to make presentations. We're empowering them to take charge because they have the ultimate power. So we formed the coalition, which is called the Health Promotion Advisory Coalition, which we think is a blueprint for health promotion across the nation. And if you look at the board of directors being represented in this HPAC, which I'm calling HPAC, board of directors are Hispanic, an Asian, African American, Caucasian. So you can see how male and female gender represented equally. We have a steering committee. The Diabetes Coalition is 50 members strong. Safe Kids Coalition has been in existence. Healthy Heart Coalition is 60 members. 60 agencies strong, along with community members, all the stakeholders, American Heart Association, everyone you can think of. Smoke-Free Coalition, again, 90-member agency. Again, all of them are working on PSE changes. Asthma Coalition, Interfaith Coalition, Women's Health Network, to bring all of them together. The co-chairs of all of these coalitions formed the steering committee. And ultimately, we formed the HPAC, which involves all the 14 mayors of the municipalities, because we feel these are the grassroots people, the coalitions. The HPAC is the grass top. That is the elected officials who are making the decisions. And so the mayors and the university presidents and everybody's involved, the chambers of commerce, etc. Some of our cool initiatives are, we're becoming from the health educator. Like I said, we have always been out there just giving presentations rather than empowering the community to take charge. So we're moving from health educator to a community resource champions. That means we are educating the community to become community resource champions so they can go educate their members. And we also won the award for National Leadership Academy for Public Health, which was we were one among the 20 teams across the nation. We were able to build the Asthma Coalition because of that public health award. That means not monetary. They were just providing us coaching. We connected the Public Health Center private resources. This poster is very emotional to me. This lady, this small child, Brennan Passons, she passed away October of last year, or 2010. And I keep her picture on my desk. Her mom emailed me today morning and said her daughter who passed away and Sarah are in spirits with us today. So that's her mom over there holding the poster. You can see how we've empowered the community. I feel they are the community to be voice champions, to be the spokespersons. And the African American couple that you see over there are this child, Kellen's mom and sister. And so how we were able to connect both of them to an Asthma Coalition Summit, and they are taking the prevention message far and wide across Fulton County. And if we can prevent another child from dying because of asthma, I think we've done our work. But hearing from Sarah is if only she knew. That's all she talks about. She's still grieving, but she says if only she knew she had to give an EpiPen to her daughter, the daughter would be alive. So I do have Brennan's picture on my desk. She gives me energy. That's what keeps us going. We became from the boardroom to the boulevard. How many of you know where boulevard is? Excellent, all of you know. So we've passed policy changes already. We've started with Head Start centers. We've implemented the school flag program about outdoor air pollution. And we've gone to Governor Deal's office, but also we've gone to the streets, the boulevard. The people whom you see on the down slides, they are old gangsters. We've become their friends, and we are old gangsters, so don't mess with us. We brought them out of their area of comfort and brought them to screening services. Walter, his name is Walter, very close. Every time I go to the parking, hey, sweetheart. So very, very good friends. They've gained our trust, and so have we. And they never knew there was a health center just 10 steps across. That was the worst part, because we keep saying social determinants. One is access to care. They just had to take 10 steps. The no transportation problem, no mileage problem, but because they were left out of the system, all they needed was to be reached out. And I just took a few handshakes and a couple of smiles, that's all. And pointing fingers to listening, that's what we did. We formed the Interfaith Coalition, comprised of the Jewish community, Islamic community, the Hindu community, and the Baha'i community. And they started focusing on health and prevention. The interesting part with this coalition was we were not speaking the same language. Public health professionals were speaking a different language than the faith community. So when we started the coalition, when we started the vision statement, I said, by 2013, we have to do this with SMART objectives. They said, wait a minute, what are you doing? They said, we'll have our aim statement. Our aim statement is faith communities united for health, your body is a temple. So, it was just listening to them. We got their buy-in, and they're empowered, and they're making policy changes at this time, community gardens, and also they're passing nutrition policy in their congregation. We came from convention and seminars to corner stores and community gardens. So yes, we do provide conventions and seminars to the community. Also, we did a corner store network survey in the Boulevard community, where we realized that almost more than 60% of the Boulevard community goes to their mom and pop store to get their groceries. And it's a food desert. So how do we address food deserts there? We're starting to build community gardens. And this is one of the community gardens that we were challenged to, but got it finally because the community had the power to make it happen. And moving to the next step from health to our health-onomics. So this is this flowchart is being put together by Rodney Mullins and myself. Rodney Mullins represents the HPAC co-chair. He's the community liaison. So you can see when you work with the community, great things happen. Great things happen. It's just that sometimes they're always left out of our decision making and in our boardrooms. Bring them to your boardroom, and they have great ideas. So Thank you. So you can see the core. The core is the community coalition, and we are looking at. We went to the boulevard and we started talking about eat healthy, eat apple, eat this. They said, no, all I'm looking for is a job. So can you see how public health professionals forget the economics part? So talking to Rodney, he was sort of talking with economic language, and I got interested. Can you talk more? So we combined forces and we said, okay, let's promote this as our health-onomics. And whenever we're giving out the health message, we need to give out the economic message too. So that's the chorus, again, the community coalition. They have the power to take this further and help and make it into a healthy school, or either individually being empowered, and also making them into community resource champions, as I said before. Finally, challenges, gaps, and opportunities. I don't know how many of you were here when Sir Michael Marmot came and presented. How many of you did listen to his lecture? Great. I think that was the best lecture I've ever heard. But he says, do we have the knowledge? Yes. Do we have the means? Yes. Do we have the will? And someone earlier asked a question, what is the right thing to do? Excellent question. And to do all this, we didn't have any money. I just had 4 staff in my team. But I knew money was not everything, and I knew we had all the assets and resources in the community. Just getting them together and making it as a value-added work for them would make things happen. So with $0, we knew this was the right thing to do, to get the community empowered and to be the healthiest county in Georgia. And as you can see from the big picture, it's about getting the community together. Being an Asian, I've heard from both the sides. And it's interesting because racism does exist. I can't deny that. But how do we find the common ground is the answer. Just like as this big picture says, if one is affected, we're all going to sink. How do we all come together? So thank you. That's all I had to say.
Thank you very much. Our last speaker is a recent collaborator with Georgia State University, and it's a little unusual for me, being more of a demographer, pure researcher, but it also provides really exciting opportunities. I'm going to introduce Tony Barbagallo from Booz Allen Hamilton, who is a sponsor of this particular summit, but is also working with us to put on other health disparity summits. So let's have a big hand for Tony Barbagallo, who's replacing Richard Fogelson.
Yep, and I'll try to do him justice. I want to thank you all for being here today, and I want to echo Jazz's sentiments that the turnout was really great, and it was really exciting to have everybody here together because as a co-sponsor, we're really pleased to be collaborating with Georgia State and with Habitat for Humanity on doing this work. And the title of the talk here is Perspectives on Change, Community Health, Health Disparities, and Health Equity. But I'm really here to answer Jazz's question from last night when he asked, why are you here, or how did you get here? So do I just press the green button?
The one on the side to the right.
Okay, so let me start by saying who is Booz Allen Hamilton. And we're a global strategy and technology consulting firm. So we're a bunch of consultants that we've been at the forefront of management consulting business for over 90 years. As a matter of fact, next year we'll have been in business for 100 years. We have more than 24,000 employees, so it's me and 24,999 of my best friends that are working on this. And we provide a broad range of services in strategy, operations, organization and change, information technology. And we're headquartered in Washington, D.C., where what people affectionately call Beltway bandits. And so we work a lot with the federal government on a broad basis of things. But a lot of what we do is in health, because a lot of what our federal government does and with your tax dollars is provide health and health services and public health. We have our largest office outside of the metropolitan Washington, D.C. area is here in Atlanta, where we have over 450 employees based out of the office just a few blocks north of here on Peachtree Street. Actually, not that many people are in the office. Most of them are working with clients on client site, and a lot of those are working with the Centers for Disease Control. So the story of how we got here, or why am I here, is management consultants and consultants, a lot of what we do is we work at the intersection of what and how. How are we going to make the change? What is the problem, and how are we going to make a change? And about 10 or 11 years ago, some of the partners that are the authors on this book here called Mega Communities started asking the question, the tagline on Booz Allen Hamilton is making change that endures. And that wasn't always true. A lot of the projects that we help people change things fell apart afterwards, and some of them did stick. And so these partners asked the question, what makes a successful project? How is it that we make changes that actually happen and endure for the long haul? And the result of that research was something that they formulated into a theory called mega communities. They said in order for change to really happen on a large scale like this, you needed to incorporate all aspects of the problem. You had to bring to the table the private sector, you had to bring to the table the NGOs, the community-based organizations, the community representatives, and you had to bring together the governmental sector all together at the table to understand what the problem is, hash it out, frame the problem, and start thinking about possible solutions to the problem and how we might address it. In this book, and there's a workbook behind it that you can see, they acknowledge the fact that you will not get everybody to work together. But one of the things that you will probably do is diffuse people working against each other. So as long as people understand where we're coming from and what our issues are, we can try to address them and to diffuse the issues that might cause, what was it that you were talking about, the less distrust. Reduce the distrust and the things that will diffuse the opportunities for success. And so I think it's a really good read and something that we've taken forward in our approach to a lot of the community health-based projects that we've been working on. Over the last 5 or 6 years, I personally have had the pleasure of working with the CDC on a variety of community health projects supporting change across the country. And these include some of the ones that you guys in the room here are probably aware of: REACH, Achieve, STEPS, and the Strategic Alliance for Health. So Booz Allen Hamilton has been working with the CDC and providing subject matter expertise and coalition building expertise for these community-based grant programs. So we bring the grantees together and we provide them with expertise in the particular area. Most of these grant programs are addressing tobacco cessation, nutrition, physical activity, and obesity. And so we have subject matter expertise on the health issues and the health problems, but we also bring the coalition building, the mega community approach, how to form coalitions and how to engage people from the community. We also bring marketing and communications expertise, how to speak to the community, how to transmit to the community and to the other parts of the community what you're working on, as well as how to speak to authority, because somebody else said it's about policy. And so the grants are directed at policy change, and policy change is done by local, municipal, or state government. And so you want to change policy, and how do you communicate what your objectives are, what it is that you're trying to do to leadership, to governmental organizations, to administrators, to the mayor's office, or to the city council. And so communication is an important aspect of this as well. So we try to support, provide support across all of those in technical assistance. As a result of that, personally, I've been looking for opportunities to get engaged with here in Atlanta, because none of the communities here were local. Well, some of them were, but they were in earlier cohorts. And so we haven't been engaged here locally, and I was looking for opportunities to collaborate with local communities. Another thing that we, Booz Allen, developed was, well, I'm showing pictures of books. We're consultants, and what we like to do at the end of a project is wrap it up into a book and say, hey, we created a toolkit. And so this is a framework for convening a community summit. Over the last 5 or 6 years, Booz Allen has been working on a pro bono basis, bringing together community summits, addressing change one-on-one with various communities. And so what they've done is they've used this mega community approach to address problems, talking to leadership in communities to figure out what the issue is in a specific community. I want to say that a lot of this work was originated out of our work with military health. So it was around Veterans Affairs, reinstituting, bringing people back into the community, addressing issues like traumatic brain injury, substance abuse, mental health issues in the community. And so they formed these community summits, and these summits were unlike today's summit, which is addressed at research, was really specific, topic specific, and how to have a resulting action plan coming out of it, identifying who the people are that want to work on the project, and leaving the room after a summit like a day-long summit with action items and an action plan that's going to go forward and kicking off a project. A lot of people that come to these summits, I've been to a couple of them, are surprised when they walk away with to-do items and action plans to work on, because that wasn't what they thought. They were coming here to listen and talk and to listen to Booz Allen speak to them, and instead they're sucked into group dynamics and group discussion, and suddenly realize, like, if you do that and you do that, you do that, I guess I can do this and make it happen. The last thing that I want to talk about, though, is briefly is health equity, and our work with the community grants, the Achieve, the STEPS program, and so forth, and the support on that. One of the things that's in those grant programs is addressing health disparities and health equity issues. And in conversation with the project director at that time, I was saying I'm not sure that we are really doing a good job of providing support around this issue of what is health disparities, addressing health disparities and health equity. And I heard again earlier today is sometimes some of the things that we do have unintended consequences and actually increase the disparities. So if we are working on obesity reduction issues in a community, but we don't do it in an equitable fashion, we may decrease overall obesity, but the impact may be disparate, and we actually may increase the disparities. So how can we bring some capacity to our grantees and to our organizations and communities so they understand what health equity is? And it was really interesting doing that because in talking with a lot of people, the terms health disparity and health equity are not well understood and used interchangeably. And so just setting the definition for it was an important task in and of itself. There's more and more work that's been done in this area, but it was interesting doing the literature search on this, and some of my colleagues were in the room on this. There was not a lot of literature on this type of work in terms of developing health equity capacity. So I think that this was an exciting opportunity to do a Health Equity Capacity Institute. And when I say institute, all of these conferences that we did for the grantees were referred to as action institutes. So they were learning opportunities that were supposed to lead to action. So we titled this a Health Equity Capacity Institute. And the evaluation feedback that we got was very, very positive and energized a lot of people. And the idea of level setting our conversation around what is health equity, what is health disparity, and what is actionable for us was really important. And it really empowered people because a lot of people have good ideas about this, but they're afraid to talk about it because this is a really charged subject, of course, when you start talking about disparities and you're talking about racial, ethnic, age, and other types of disparities. And people are very concerned about how, if I make a suggestion or ask a question, how will this be addressed? So having these conversations and level setting for an organization was a really empowering type of opportunity. So as a result of these things, I was offered the opportunity through my colleagues to say, do you guys want to do one of these health summits in Atlanta? And so we looked for an and I said, sure, what's the topic? And I said, well, I'd like to further our work with health equity and see if we can find some folks here in Atlanta to work on a specific public health topic here in Atlanta. And I called up Michael Erickson here at Georgia State University, and he hemmed and hawed a little bit, and he said, well, we already have a research forum that's scheduled for March. So I was glad to be able to collaborate on this research forum, and we hope to have our forum, which would be much more of an action-based forum, sometime this summer, as tentatively probably in June would be our target date. And I think I've spoken to some of you already in the room because we started gathering data on what might be the appropriate topic that we could focus in on and take action forward on. So I think that's my last slide. I hope it is. Yes, so we hope to see many of you at this Community Health Summit that we're planning for this summer. And again, I want to thank you all for coming, and I look forward to talking to a lot of you again here in the community on what the possible topics might be, and I look forward to collaborating with some of you on some of these action items.
We have time for a couple of questions. Anyone have a question on the research for Fulton County? Yes.
Hi, I have a question for each of the first two speakers. I'm Kamara Jones from the Centers for Disease Control and Prevention. And these are really dorky questions, so they're not like deep and theoretical. For Dr. Bonney, STI rates, do they tend to change with age? Do they tend to go down with age? And if so, how did you account for that in your analysis when you were looking at the trends?
Sure. So our analyses are pretty preliminary right now, so we haven't really done any analyses to look at age, but I do believe we did see that most of our STIs were found in our younger people, and we expected that.
Right. So it's just, so the power of your study, I must say, is the longitudinal nature of it. But as you're dealing with a closed panel and following them longitudinally, some people who might not, I understand the factors that you're looking at, but other people might criticize you and say, well, it's just because they're older and wiser now. So it's just something to look at as you analyze it, or maybe find some other people that you could track.
Right, yeah. Thank you. That's really helpful. I think that certainly we'll address it in our discussion, and we may say that, sure, it's longitudinal, but we're not following them for a 10-year period or a 7-year period.
It's just a short period.
It's a short period, so the difference between STI rates in, say, a 24-year-old versus a 29-year-old might be X, and we'll state that. So that's really helpful.
Thank you. And then my second question is for Dr. Hemphill-Fuller. I didn't know what the difference was between high traffic and AADT. Mm-hmm. I forgot what AADT stands for, but...
Okay, so AADT stands for Annual Average Daily Traffic. And so for all of the major interstate and state highways and some local roadways, the State Department of Transportation collects data on the number of vehicles that take that route every day. So for a corridor like 75 and 85, it's probably about 260,000 vehicles who actually use that route every day. So the AADT would be 250,000.
So what was high traffic? Because high traffic fell out of your multi-level regression. Well, if they were highly collinear, of course.
Right.
So I didn't know what high traffic was.
Yes, so high traffic is something that we delineated, and so we decided that was going to be a roadway that was greater than 10,000 vehicles per day. So 10,000.
So it's a plus or minus, it's a binary variable?
Yes, it is.
Okay.
And that's because we had a lot of variation in terms of the major traffic corridors and each of our different census tracts. You saw some were very close to 75 and 85 and really bordered it, and some were far away. But we still wanted to see if we could capture the within census tract variation by looking at least the busy roadways that were in each census tract. And so the high traffic, we said, would be greater than 10,000, and low traffic would be less than 10,000. So in areas around those. So probably not seeing that predictor coming up in that model is because our cutoff is really very low. But that's something that we did so we could try to look at the within census tracts and see, at least within the census tract, a high area versus a low area, and does that make a difference? But between census tracts, not much of a difference.
Thank you.
Mm-hmm.
Okay. My question is for Dr. Dawood. Okay. Curious about your program. You said you're empowering communities. So it's just Fulton County, but are you going to like the Cobb County because they have situations that they need help? You have Cobb County that has situations that need help. So I know we're talking about this collaborative effort, community-based. So are you working with other health departments in other counties to try to get them to come aboard with your program?
At this time, we're just working in Fulton County, but I've been in contact with my counterpart in DeKalb County, and she really likes what we've been doing with the model, the HPAC. And yes, we're hoping, as I said, as a blueprint, take this as a blueprint across the nation or even across our counties.
Okay. Yeah. Thank you.
One more question.
Hi.
Sorry.
Hi, I'm Meng-Hui Chen on the epidemiology at the Epidemiology and Analysis Program Office at the CDC. And first of all, thank you so much for coordinating this meeting, for getting everybody together to discuss this important topic. But I would like to take this opportunity to, actually it's not instead of the comments, but in states to make announcements. I want to let the audience know, maybe many of them already know, the CDC actually publishes a health disparity report on the first report, actually about 2 years ago. On 2011, January, we have a first release report on health disparities. And we are planning on the next couple months, we are going to publish another report. And the majority of the issues about the purpose of publishing the health disparity report is to equal the Healthy People 2020 the objective, the overall ultimate goals to increase the quality of life and as well as to eliminate disparities. And our first report, 2011 report, we have about 23 topics which are related to majority. Some of the topics discussed today are related to the environmental health, and also with the social determinant of health, the mobility and also mortality, and also with some topic related to access to care and also to environmental health. In the next report, for 2013 report, which we plan to release for the next couple of months, we'll be updating to the original topic, which is 23 topic, as well as we also include a couple of new topics, such as disability and food desert, and also has environment, environmental health. So we have a couple of new topics, very exciting topics going on, and maybe some of them already have a chance to review this report, and your feedback actually welcome. Let us know about what you think about this report, and we would like to discuss more in the future. Thank you so much. Thank you.
Thank you. We look forward to reading those. We are really running out of time.
Just one.
It's okay. Very short question.
Okay. Thank you. Thank you a lot for your presentations. It was really interesting. And I've just seen that a lot of work is being done on different levels by different stakeholders. But I was wondering whether, is there any, unit or coordinating mechanism on state level or maybe on Atlanta's level that you can guys, to sit together on a regular basis to share with their findings and to share with what kind of public efforts are being done on grassroots level and how you can coordinate. I don't know the structure, so it's just what was wondering.
Good question.
Thank you so much for that question. So I've already talked to Tony, and we are meeting soon about how we can coordinate efforts more in Fulton County. And Christina Fuller, Dr. Fuller is already a part of our asthma coalition. And we just met and we talked and we said we should. We have a huge HIV department and how we can collaborate. So we are trying our best, at least from here, right?
Anyone else want to add in?
I just want to say I think that this forum, the forum that we hope to put on in the summer, will be good opportunities. And through some of the folks that I've talked to here in the model of 6 degrees of separation, which, by the way, I heard the other day through Facebook, it's now 2.7 degrees of separation. You can connect to anybody in the world in 2.7 connections on Facebook. I've also found other coalitions and collaborative efforts that are in the metropolitan area. So I think if we continue to meet like this and try to reach across those and form some structures, formal and informal structures to collaborate, that's going to further and kind of go towards that, what I talked about, call a mega community approach.
Thank you. So, and I might say that this could be a role that we at the Center of Excellence for Health Disparities might consider important to take on. That could be something that, in terms of our community outreach as well as our education goals, is something that we could also be involved in and take on.